Hello everyone, thank you for coming to this video, and in this video I will try to explain about the descriptive study designs in pharmacoepidemiology as part of a lecture for public health pharmacy with pharmacoepidemiology course at Department of Pharmacy, University of San Carlos, Philippines. As an overview, I will begin this video with some introduction about the general about study designs in general, and then I will continue to some descriptive study designs including the case report, case series, analysis of secular trends or ecological studies, as well as the cross-sectional studies. So let's move to the introduction. And usually in the research, the researchers have an intention to search for causality relationship. So when there are some factors that become the research interest, they will examine whether there is a causality relationship between those factors. However, before doing the causality assessment, as I explained before 2 weeks ago, association must be established, and this can be established by using inferential statistical procedures. So when the researchers find a good association, statistically significant associations, then they can continue the research to the causality assessment. In pharmacoepidemiology, we borrow the study designs from epidemiology, and some experts group the study designs into two large groups. The first is the experimental design, and then in this design there is a big a general design that is called as randomized clinical trial or RCTs. It is often mentioned as well as randomized control trial. And the second group of study design is the observational study designs. These include many study designs, including the cohort studies, case control studies, cross-sectional studies, analysis of secular trends, case series, and case reports. And actually there are some kind of designs that I do not mention here, so I think it is just variations of these study designs. Okay, and then some experts may classify those study designs into two broad groups that are descriptive studies and analytical studies. So in this learning, in this video, we will closely look at these descriptive studies. And please note that in both groups we can see the cross-sectional studies. So cross-sectional study design can be used for descriptive purpose as well as analytical purpose. And then some experts also classify or try to put all these study designs into what is called as pyramid of evidence, or in this illustration I will just use the triangle. So they put some kind of hierarchy from case studies to systematic reviews and meta-analysis. And actually right now there are ongoing trend that are evidence is not enough to be only generated by systematic reviews and meta-analysis. There is kind of research that is called umbrella reviews, there is systematic reviews of systematic reviews. So the science, the study designs is evolving, and some new designs may be born later on. So only the systematic reviews and meta-analysis, we called it as secondary research, while the primary research is randomized, includes the randomized control trials till the case studies. So this triangle may also represent the quality evidence as well as the risk of bias. So the higher the positions of a study design, the better of its quality of evidence. So we can say that the evidence coming from RCT and RCT could be better than could possibly better than evidence that is coming from the cohort studies for similar topic. So we rely more on research that use a randomized clinical trial as well as these systematic reviews and meta-analysis. And then this triangle also depicts that about the risk of bias. The lower the position of the study design in this triangle, the higher of the risk of bias. So talking about risk of bias, we should also understand two other terms, which are chance and confounding. What is chance? Chance error that is caused by random variations. So this is not because of systematic errors or that will cause the bias. So in chance, we can minimize error by using the adequate sample size. We usually use sample size calculator and so on. And we can use statistical analysis to eliminate the chance. Yeah. Not to eliminate, to understand that the result is not by chance. So and then the bias, as what I explained before, is caused by systematic variation or systematic errors, and this bias can be there are many types of bias, and usually they are classified into two types of bias. The selection bias. So bias can happen when we select the participants or patients to as our sample, and then also bias is classified as some bias are classified as measurement bias. So and we have to take care of this when doing research. And we have another term. The term is confounding. Confounding is factors that affect the interpretation of outcomes. Yeah. For example, when we the example here is people who carry matches are more likely to develop lung cancer. When we observe that the intention of among patients with lung cancer, we may probably find that some of them may carry matches everywhere. So the question is that do matches associate with lung cancer? Of course not, because probably the smoking behavior is more likely to cause lung cancer than carrying matches. So smoking is the confounding factor. Usually the confounder should must have two requirements. The confounder must be associated with the exposure, and then the second one, the confounder must also have an association with the outcome. So the confounder usually making the researchers difficult, or making what's confused about how to interpret the results. So, and in pharmacoepidemiology, we have a general term for confounding, for confounder, that is known as confounding by indication. Usually, this is quite related with the study in pharmacovigilance, or the study of adverse effect of drugs. And when confounding by indication is because the progression of the disease. And then in doing a research, we have to consider some ethical aspects of the research. Then there are 4 principles in biomedical research that we have to consider. The first is respect for autonomy. The second one is beneficence. The third is non-maleficence, and the fourth is justice. This can be these 4 principles can be formulated into some questions. For example, we have to question ourselves when we do research. What information to give before seeking consent? What kind of information that we need to give to the participants before they sign the informed consent form? And then what kind of deviation from normal clinical practice that we have to explain as well to the participants. This really required, especially for the randomized clinical study design, because in this RCT, in this study design, particular study design, the researchers may give an intervention to the participants. So there will be a deviation from the normal clinical practice. For example, if we group the participants into 2 groups, the first is the case group, and then or the exposure group, and the second one is the placebo. So the placebo is not the drug that is used for the normal clinical practice. So the patient should understand, must understand this. Also, we have to explain the burden that will be imposed on participants as well as the risk. So this is part of the I think the non-maleficence principle of ethical research. And what benefits? This is a part of beneficence. What benefit my participants or others receive, and also the benefits for the society or future patients. And then reveal the patient identities. This is related to the respect for autonomy for the patients. Okay, that's all for the introductions, and now we will move to the details of the descriptive study design, starting from the case reports. So case reports are usually reports of events observed in single patients, but usually the reports from 3 patients also can be also considered as case report. Some experts suggest 3 is the maximum number of patients that are examined in case reports. And usually the case report is used to describe a single patient who is exposed to a drug and experiences a particular outcome. So we give a detail of what kind of drug exposure given to the patient, and then we also explain the particular outcome of interest. Usually the outcome of interest is outcome that is rare, that is we can say new, or probably has been previously reported, and we can report it using this case report to provide more evidence for this particular outcome. In pharmacoepidemiology, usually we use this case report to examine the adverse outcome from the use of a drug. And in the next meeting, I forget which week, we will learn how to use the case reports to assess the causality of adverse outcome, causality relationship of an adverse outcome. Case report usually very useful for raising hypotheses about drug effects, but we have to bear in mind that because the number of participants that are studied in this case report are very small, we usually cannot generate this the conclusion or the hypothesis got from this study to generate the results for the general populations. And then the hypothesis that is gathered from these case reports should be tested using better study designs. We can use the descriptive study, other descriptive study designs such as case series or cross-sectional studies, or probably also analysis of secular trends. However, the investigators cannot determine whether the adverse outcome was due to the drug exposure or would have happened anyway. Therefore, causation is rarely generated from this study. So, like what I said before, we can usually in case report we cannot measure an association as well. So we just give temporary conclusions or hypothesis, just like that. So this is very weak in providing evidence, except for a specific condition. If we are studying about adverse effect, if we study adverse effect of that when the outcome or the adverse effect is very rare, and also the characteristic of exposure is also rare, from this case report we could probably establish not a causation but stronger evidence than if we compare with when we have the outcome that is not rare. For example, the clear cell vaginal adenocarcinoma in young women exposed in utero to diethylstilbestrol. When the mother of a baby used diethylstilbestrol, the baby in later life they can develop clear cell vagina, or having a risk for clear cell vaginal adenocarcinoma. And then the disease course, the exception is when the disease course is very predictable and the treatment causes clearly apparent. The treatment causes a clearly apparent change. For example, the ability of penicillin to cure a streptococcal endocarditis. And then when the case report is reported using challenge and re-challenge information, we can also establish better evidence. Challenge and re-challenge is in studying the adverse effect is happens when we suspect a drug that may cause an adverse effect, and then we stop the drug to the patients and we observe that the adverse effect disappear, and then we give again we repeatedly give the drug, and then the adverse effect appears again. So that's a challenge and re-challenge situation, or challenge and re-challenge method. So that's for case reports. Let's move to the case series. Case series is actually similar to case reports, with the exceptions that the number of patients are more bigger than the case reports. Usually we can have two type of case series. We can observe, we can make an observation from the clinical outcomes, from the exposure first, or the clinical outcome first. So this is the probably the graph that will make you easier to understand the context. So the case series can be conducted by grouping some participants that using a particular drug, let's say drug A. Then from these patients we can observe multiple outcomes, and we try to create a kind of hypothesis as well, not an association, from kind of this observation. And the second case series, we can start from the outcome. So we group patients from the outcome, and we try to trace back about the drug exposures, about or the drugs that are used, the medicines that are used by this type of patients. For example, when we have 100 consecutive women under the age of 50 who suffer from a pulmonary embolism, and note that 30 of them had been taking oral contraceptives. So here we use this kind of this second design. So we observe the outcome of an outcome, the pulmonary embolism, and we try to trace back what kind of medicines that are taken by the patients. And we note that among 100 women under this investigation, 30 of them using oral contraceptives. So in this case series, the evidence probably may not really clear, so we have to do we can scale up this research into probably the analytical studies, such as case control studies. So okay, and then let's move to the explanation about analysis of secular trends, or we can also usually call it as ecological studies. Analysis of secular trends examine trends in an exposure that is presumed cause, and also trends in a disease that is a presumed effect, and testing whether the trends coincide. We can examine the coincidence by using time, or we assess the temporal relationship. We can also assess by we can use a spatial approach using the geographic boundaries. For example, usually the analysis of secular trends, this method using vital can use the vital statistics such as government records of births, marriages, and death. And then we can use also sales, marketing, and claims databases. For example, using the sales data, we observe the oral contraceptives with death rates from venous thromboembolism recorded in vital statistics. But we have to also understand that probably the death is not only the death of people that use oral contraceptive, probably not because venous thromboembolism, but because also of other causes. So but by using this data, we can really establish the analysis of secular trends. For example, we can see the mortality rates from venous thromboembolism was seen to increase in parallel with increasing oral contraceptive sales. Then in here we can find a hypothetical relationship between the mortality from venous thromboembolism with the use of oral contraceptive. Although the associations is probably are still rough. And then usage for this analysis of secular trend. This is very useful for rapidly providing evidence for or against a hypothesis. And analysis of secular trends can be also used, for example, in this age of pandemic, and we can do this to examine, for example, the use of some drugs that in the beginning of the pandemic are recommended to treat the COVID-19 with the data of mortality rates from COVID-19 from many countries. So we can check whether there is a relationship between the use of particular drugs with these the mortality rates. But like what I said before, the associations is very rough. So the drawback is that lack data on individuals, because we only observe the aggregate data, only using the aggregate data, and then we cannot control for confounding variables. And then usually the ecological fallacy results if inappropriate conclusions are drawn on the basis of ecological data. So drawing a conclusion from analysis of secular trends or ecological studies are not easy, because we have to be very cautious to draw a conclusion from this type of study. And then the last descriptive study design that we will learn in this video is the cross-sectional studies. The cross-sectional studies gather data from participants only once. So we only gather data once from the participants, usually or at one point in time. Usually if we gather data from the patient once, it doesn't mean that at just only one day, but we can do the research in a specific period of time, for example for 1 month, 2 months, 3 months, but we gather the information from each participant only once. Now This is also called as hypothesis generating study or a survey, or if the survey is very large, we can call it as a census as well. So this cross-sectional study can be descriptive or analytical. It can be descriptive if it aims to describe the big picture of the exposure and the outcome of interest. So from a survey, we can generate many hypotheses, and then we can select which one, which kind of hypotheses that are interesting to provide a kind of guide for future studies. And then the second type of cross-sectional studies is the analytical design. The analytical cross-sectional study is to demonstrate an association between an exposure and an outcome. So when the descriptive is just only to describe the big picture, and then for the analytical design, we want to establish an association. So usually we involve the statistical analysis in these analytical studies. For example, this is an old study from Paulos Ram et al. He analyzed the US National Health and Nutrition Examination Survey from 1988 to 1994 to estimate the frequency of analgesic use in a national representative sample from the US. In the findings, he explained that 140 million adults use analgesics monthly. So this kind of thing is kind of descriptive, not analytical. And then here, women and Caucasians used more analgesics than men and other races. Again, this is more sounds more descriptive rather than analytical. And more than 75% of the use was over the counter. Again, this is the descriptive. And also the Paulus Ram also describe the analytical results from his study. The finding is that the associated factor to psychotropic medications, so they examine using statistical procedures the associations between the low socioeconomic status with use of psychotropic medications, as well as the lack of high school educations as a risk factor of the use of psychotropic medications, and whether subjects were insured with this kind of thing. So we can call that these are some risk factors, of using psychotropic medications. So that kind of thing is the analytical study design. So in one cross-sectional study, the report can be two, the descriptive one and the analytical one. But usually nowadays they report it in one type of one report. So yeah, in cross-sectional studies we can see the section that is more descriptive and the other section is more analytical. Usually the descriptive is put in the beginning of the results explanation, and then the analytical is after the descriptive explanation. So, and then the problems with cross-sectional studies is that often unknown whether the exposure really precedes the outcome, because we only take the data only once, the data from the patients only once, or the participants only once, and the exposure as well as the outcome are measured at the same point of time. So we need better study designs like cohort studies as well as case control studies to separate the exposure and outcome in the timeline to establish a more adequate temporal relationship. Okay, thank you for watching this video. I'm sorry that my English is not really good at this time, but I'm hoping that you understand what I already explained. Please take notes for some questions, and we will discuss this in our synchronous session. Thank you so much.